Ladies and gentlemen, good morning. My name is Jens Chapman. Please apologize for my getup and my nasal voice. I'm not infectious anymore, so I've heard, but there may be the occasional cough. In fact, Daniel, could I bother you to get my water bottle up here? I so apologize, but thank you. So thank you so much. I'm obviously one of those older school guys, and we're doing an acute spinal cord injury downstairs and a neurofibroma that's quite twisted. It's an acute cord deterioration, so there's no robot in there, but we'll have a 3D CT, but no navigation. So the future is here. I love this current depiction of our Sisters of Providence Tower because, again, it reminds me of a space rocket. The future is really here. This is a great conference because it really puts people of all backgrounds together to explore where we're going. I don't think I have any conflicts of interest, but I do sit on a steering committee in the Providence St. Joseph's healthcare system that gets to decide on some of those things. It's always awesome to work with Dr. Patrick Johnson here. He's so much way cooler than me in all regards. LA guy, cowboy guy, just cool, has the latest stuff. I'm just so envious of him because, again, this is me, rainy Seattle, macro spine surgeon and workman. And I want to congratulate Daniel also. He has all of these things, but you can see how much he is a psychologist also in his choice of titles. This is called positive reaffirmation, right, Daniel? So he's given me a topic that he knows I'm not necessarily in favor of, meaning high tech. I'm an old school surgeon, so by giving me a high-tech topic, he thinks that he can assuage me into the future. Very clever, because this is a semi-obligatory conscience lecture, also known as the dinosaur professor lecture, the old Yeller lecture. So this has obviously always been my role in these things. We all have the same goal. These are the three things: accuracy, consistency, efficiency, no question. And again, this is a rapidly evolving field. I don't know whether you know that, but there's this Israeli company that now has the first FDA clearance for hands-off deployment of tools, high-tech in the spine. It's right now just for IR procedures, but you know what? The future is here and is now, and it's a rapidly evolving space. So just look at this and check out their website. It's a beautiful website. It's actually interactive. It's like a video game. It's kind of really cool. It's common as we're looking at technology evolution to look at navigation. And again, this is my dear Munich, where I'm from, circa 1970. So the post-World War II high-tech was a Falk city map. And of course, nobody thinks about it anymore. I want to point out I'm not a technophobe. I'm an Apple Watch fan. And I have a beautiful watch collection courtesy of my father at home, but I wear this only and I use it all the time. So I consider myself not a technophobe. All of you have heard of Moore's law, right? Processing power is amplifying. This is a very linear, actually a logarithmic rise just over the last 40 years that has made this kind of a seamless immersion of technology into our world possible. And again, this is nowhere close to where we're going because we're actually trying to go beyond Moore's law into an exponential circuit as we're getting into quantum computing and crystals instead of transistor technology. So these are Moore's law. I recommend you watch that video on YouTube about Moore's law. It's great to see this visionary talk about transistor technology development and then see some people beyond Moore's law. It's really just mind-opening because we're nowhere close to where we will be, quite obviously. There's a counter law that's called Wirth's law, and I did not put a slide in on that. I forgot that before. Wirth's law, W-I-R-T-H, which basically says that the more complex these technologies become, the more your software is going to bog you down. It's a great counter law. And this is, again, the fear that we're going to be replaced by robots. Now, here we're in November 2019, Seattle, and a little bit south of us, there was a great movie, and I want to try to kind of relate how we are attempting to predict the future in a meeting like this with the movie Blade Runner. Anybody know the movie Blade Runner? The younger generation, the millennials? Yes, some? I was in medical school at the time, Munich, 1982, when this came out, and I loved the movie. It was fantastic. Now, I think this is a great movie to use to analyze how we're predicting the future and how we fail with this. This was created in 1982 from a 1968 novel, and it plays in LA, right where Patrick came from, in November 2019. Did you know that, Patrick? Patrick was not a star in that movie, but he could have been. Human fights 4 robots, replicants in that movie, to save mankind. That's the main theme. And again, the main point of this movie was man has made his match, now it's his problem. I want you to think about this line as I'm going to expand on a little bit of these robotic themes and navigation themes. And I'm going to suggest that we have a term for this that I have not seen coined before, Robo Nev, combining robotics and navigation. Where are we in 2019? Okay? So this is a list, and I'm not going to read through this, don't worry. But you've heard some of them in the very honest presentations by Daniel and his flow lecture, which is wonderful, and Patrick Johnson also. I mean, there are cost factors. There's access, systems compatibilities, upgrades, always changing. Calibration time, honestly, 15 minutes plus, right, Ed? As you're taking a step, 15 minutes minimum. That's in flow. You heard every delay, Daniel, 5, 10 extra minutes, right? It can be really cumbersome. Interrupt can be unbelievably slick. Overall radiation exposure to patients, still not really quantified. You need to have a way better CT mapping of patients than historically is necessary. Prolonged surgery, quite clearly. So specialized personnel. These are a lot of factors that are still evolving. So where do I point this? I'm not advancing here, good. So this is the situation right now where we have multiple shortcomings, and you heard it, line of sight, clean this, clean that. And the OR where we have a simple tool like a non-ionic surface scanner that allows us a direct visualization and transformation of the visualized field into what we need to place our screw accurately, to place our decompression tools properly. That's where we really still need to go. That's effusive. So this is a list of concerns I've just listed, but the direct thing right now I want to just briefly talk about where we are here in November 2019 is the real accuracy is inflated. It's an enabling effect, and it's a long-term effect. These are the kind of sobering counterpoints I want to just bring up. I'm a little bit delayed here. Sorry, I'm a fast-paced guy. Lee's, this is kind of not advancing to my, Lee's not here. So so this is a great problem. Just like in robotics, I can't advance my slides. So just like in a robotic thing, we don't have flow state. By the way, we do need a CSNO. I think Patrick has it in his visionary OR, the Chief Surgical Navigation Officer. It's quite clear to me that we need a whole new professional category of people who help us analyze the electronic input, the signal ratios and all that to try to make sense of this. Don't you think, Patrick? You have one already, a CSNO. You just don't call them that.
No, we have guys in our operating room that actually make this stuff happen. I mean, it almost exists already. You're right. It doesn't need to be created, it already does.
So I'm going to give all the industry people, the couple of industry people here, are free 2 wishes of immediate request of mine. On the osseous side, I want to have an integrative quantitative CT capability to maximize my purchase. Okay? So this is already possible right now, but I want to have an optimal screw track for fixation, not just based upon anatomy or convenient anatomy, but also purchasing power. I want to have like the golden shot for maximum power versus safety. And I finally want to have an integration, a merging of neural or soft tissue tests and bony anatomy. Why? Because if I put a screw in a dangerous spot and there's a vena cava there, right, Peter? I don't want to go there. I want to have a red alert whooping up. Nerve root proximity, that should be solvable. Right, Aaron? We should solve that. So these are the 2 things I'm going to demand from every company right now as we're sitting here now. I want these 2 things solved here and now. This is doable. The elements of this exist. So this is where we were, and this is where I want to go quickly. Back to Blade Runner. This is a great opportunity to quickly digress in this high-tech talk about where were we right in 1983 and then 2019, 36 years later. Pan Am, Atari, gone. That was a bad prediction. But large screen monitors, which was so haunting in that movie, absolutely, everywhere. You can walk over Times Square, you feel the radiant heat. Flying cars, not yet around, but happening. I'm sure they'll be around within the very near future. I'm really delayed with my clicking speed here. So if you can get Lee, this is kind of getting annoying because the pacing is not up to par. Wireless speakers, interactive, hauntingly present now. Probably everybody is listening to everything that we're doing right now. And we're clicking and clicking. And one of these days we'll have working slide advancers. So the entire movie, pretty much in LA, takes place in rain, right, Patrick? And what's the reality on the right side in LA? Fire warnings, right? So totally off, 180 degrees off. And one other thing, smoking. Of course, everybody smokes, but nowadays it's vaping if the FDA allows it again, and e-cigarettes, right? The conventional cigarettes are very retro, I think. And then the other thing is colonizing off Earth happening, but not quite yet. They're wrong on that. But in other areas, and this is my point, technology is vastly exceeding what we had. So for instance, they had video booths to interact with, and we have FaceTime nowadays, and whatever our technology carriers, it's an absolute nobody. Now, the main thing when I want to close the arch towards robotics is the replicants like Rutger Hauer and Daryl Hannah. They looked amazingly human and humanoid. This is the best thing so far, and I recommend that you look at that YouTube video with Sophia. And Sophia is basically the closest thing we have to a replicant. It's actually amazing to watch with all the flaws that she has, but she has 110 facial features that she can perform. And it's actually surprising how this artificial intelligence-driven robot interacts with human beings. It really is amazing. So I'm having a hard time advancing this, Lee. So status check Robo Nev 2019. Very briefly, some boring stats just to underscore something. And yes, every one of those things, every one of those studies in this fast-paced world is antiquated by now. 2012, pretty large-based screw population in 1,100 patients, but that's pretty reasonable. And again, in this systematic review, whenever the slides advance, here we go. Oops, this works? Good. Thank you. So status check, here we go again. So this is the slide in question. So this measures on the left-hand side breach severity. And now allow me to do a little kind of an inference on this. This is the key number, the bad breaches. The others are radiographic cosmesis. And I want to point out something statistical. The C-arm doesn't look great in here because it's 0 to 40%. But when I see that as an editor of a journal, and I'm a reviewer and editor for multiple journals, this is an AOTM thing. This is all over the map. You know what that means to me, Clifford? This means it doesn't mean anything. It's statistically an irrelevant number because as bad as it looks, it cannot be as good as it looks. It's probably variables by human design, by human failure, but it's not a system problem. Another study, this one right here, from Spine 2007, again a little bit older, but navigation seemed to have a slight advantage over non-navigation. The limitations of the literature still to the present data heterogeneity of patients. Difficult patients are compared to slam dunk patients. Bias of authors, undeniably problematic. So experience of surgeons, a very big factor. Intraoperative qualitative techniques are very important. I have great x-ray techs, and there are 1 or 2 x-ray techs I really don't want to work with. When they're in the room, I will just really be in a foul mood. It's just not the right thing. MISS versus open, that's the other thing, and critical clinical relevance of misses. What actually mattered? If something is a little bit of skiving in, out, in, like in a thoracic screw that we'll probably have later today, it will not matter. But if something is a 2 to 3 millimeter or more than that miss in a thoracic spine into the canal, that's a big deal. Then the other thing about less invasive surgery is, are we really helping patients with just this dedication towards everything should be MIS? This is a pretty routine picture of mine. I didn't even have to look hard for this. I call this an Uzi approach. This patient has had probably 6 or 8 different surgeries to try to tackle a spine, which needed, from the beginning, because of how devastated it was, one big, definitive, cleanly done, well-performed surgery. So this is probably not necessarily an advancement to that patient. So the true at-risk patients are dysplastic deformities. I'd love to have a robot and navigation downstairs right now for this patient. Upper C-spine, upper T-spine, very small pedicles, very large patients. L5S1 is always a great subject of variability due to the lateral recesses of the foramina. And S2AI screws are way harder to place than standard iliac screws, no question. The actual neurologic deficits after thoracolumbar fractures have been also compared. And again, I just wanted to show you these kind of numbers with different techniques, but this is, again, still not anything particularly clear in terms of one technology versus the others being worse. But there's a number that keeps coming out as I've looked through article after article after article. There seems to be a 2 millimeter fiduciary tolerance. I think this is what we all can agree on. Danielle, would you agree with that? 2 millimeters is what it's all about. So this is probably the acceptable, realistic zone of tolerance we talk about as we're looking at new technologies versus old technologies. So this is the critical number. And again, we have to remember, and this is a very important point, that the spine is a mobile structure. So due diligence in terms of re-referencing is a really big deal, knowing where you can and where you can't get into something. So we're currently currently reviewing a case where there were 4 screws placed into a C1, C2 area, and 3 of those were in the vertebral foramen, were actually injuring the arteries bilaterally. The patient survived, but this surgeon probably really has not done these surgeries before, relied on navigation to try to do this because he could, and there was a clear damage. So who needs image guidance? It should be always the best for the patient, and spine surgery is hard. And again, the question is, if there are non-spine surgeons now doing this, is this really something that helps patients? Or are we doing a bad thing by leveling the playing field, kind of, so that everybody has a chance? So this is my single biggest thing about this enabling effect, and that's the false sense of security. And again, freehanding with virtual reality is a danger. Human judgment and honesty should prevail, of course. The other thing is alignment. Again, there are masters like Michael Wong who actually realigned the spine with MIS surgery, and this will become better and better understood and taught. What I see in my practice usually is MIS surgeries, and I see a flat spine with basically nothing done. In orthopedics, we call that OIF, an open internal fixation. There was no ORIF, open reduction internal fixation. The hardware placement was the primary goal, not actually making a meaningful difference for the patient. So is this MIS or not? I'm not sure, but this is, again, the problem. Now, on the tech side, the rebooting factor is a big deal. The technology, like my hand tool here, was fallible, and there's an interesting long-term effect. So how good is the virtual training that we have right now? How good are these systems teachable outside of a dedicated center like at Cedars-Sinai? And what do we do when image guidance fails? Do we just cancel the case? That may be the factor. We may just get used to that. But, and this is the most important thing for me, are we creating a generation of dependent surgeons? So we have 5, I'm proud to have 5 to 6 clinical spine fellows at all time. And a question that I hear all the time now is, we like that you guys have surgeons who don't do image guidance. Everybody does everything with image guidance. I thought this was amazing. It's a reversal of what I thought, because I felt guilty that we don't have the latest and greatest. An ethical question is, I always hear about learning curve. For me, I heard it from you before, Daniel. For me, this is a euphemism. A learning curve means complications. Is that ethically acceptable? 70 to 80 patients that would have probably not been hurt in a conventional surgery? Where is society's, where's our tolerance for that? And how can we drop this learning curve to near zero? So, of course, I'm not a technophobe. Of course, I love having new tech. I love having partners who are great with this. This is a horrible case. And again, hybrids nowadays with less invasive surgeries and image guidance make it really possible to help these patients already here and now. So this is the November 2019 status. This is the other November 2019 status. This patient was obviously operated without conventional wisdom and standard technologies. Again, I can only imagine that the surgeon's statement was, I couldn't get the calibration quite right. So that's not an excuse. In conclusions, number 1, the future is now, it's not tomorrow, it's here, and we have great new guidance and robotic systems. And this is a reality now that is exciting, that's awesome. It should not ever be a substitute for core technique, of course not. And it's honestly really not yet established and validated if you use a 2mm and neurologic or reoperation paradigm. When I say reoperation, I'm saying not 90 days, but probably 2 years. It's obviously not yet a standard of care, although it's working its way towards that. And it's currently, quite honestly, mainly a marketing tool. That's cool. But the real revolution for me is enhancing surgeons. And this is very exciting because, again, I've worked now and I've seen several companies that have really enhanced audiovisual capabilities for surgeons that are here now that make the Starfleet Medical Academy a reality, where we will have abilities to see through our visual enhanced technologies things in a patient that we can't immediately see just on the surface. This is actually really happening, and this is the most exciting thing for me beyond having a robotic arm that can execute a screw placement. So going back to the Blade Runner idea, man has made his match, now it's his problem. So we have robotics, we have image guidance, and this is fascinating, this is fantastic, this is awesome, but we should also know how to manage this. And the real enemy, and this is for me, the real enemy is not robotics, it's not navigation, it's interesting, it's awesome, it's something we need to, again, corral. The real enemy for is and could be artificial intelligence, because what we really, I think all of us agree, don't want is having AI tell us what to do with the patient. And that is a very real risk for me. Thank you.
Any questions for Dr. Chapman before we send him back to the OR? Jens,
Hey.
you bring up a good point about learning curves, euphemisms for complications. Would you rather have all our young generation of surgeons just learn open and then go out into the world and make their mistakes with new technology later, being good open surgeons and knowing what's right or wrong, having good core technique? Or would you rather them learning curve, accelerate during fellowship, have them avoid mistakes that the teacher, I hear a lot of, I hear your talks and you're always, super respect you, but I don't know what we should be doing. Because in our fellowship, there's a lot more enabling technology and just trying to push them through the new technology, getting them used to it, and then working on open kind of later on. But, how do you put this all together?
Super question. Thank you. We're in a transition phase. I think we can all agree. We have a clearly emerging technology that, again, I can't predict the future. I tried to do that with my lengthy Blade Runner diatribe. But the unexpected should be expected. I think right now, I do think in this transition period that we should pursue a dual track where our fellows are trained, for instance, on cadavers, in very stepwise fashion so that they know how to do things properly. And maybe it says backup, maybe it's just judition. And of course, the technology will take its course. Of course, they should learn in their residencies and fellowships. I really think a dual track is the right way to go. And I see no reason why we shouldn't do that right now until the technology has reached such a maturity level that it will be, Apple Watch here, a of course thing. But I think 5 to 10 years from now, we will not even have this discussion anymore because we'll so much rely on the technology guiding us properly. And yes, we'll have stories about this or that. But when I see numbers of learning curves that are in the double digits, and it's called learning curve and not complications, that's still a problem. And I think that for me, that ethical component is something that is not adequately addressed with this kind of a terminology.
I think what's interesting is, when you see those horrible cases with C2 screws in the works and everything, just horrible. I always want to know, was that spine surgeon, trained in enabling technology in their residency fellowship, or were they the guy that or gal that did a lot of open and came to a random industry cadaver course and then decided that they were the expert? That's what I want to know.
The latter is my suspicion. And again, that's one of those things that we're trying to explore right now. We don't have an immediate answer because everybody will obviously kind of stonewall there because there's pride involved. But you addressed the question of actually aptitude testing, which frankly, these newer technologies will allow us to do way better than we're ever able to do before. So instead of saying everybody gets a trophy, there'll be some who get to move forward and say that they have accomplished this goal, and others will say, carry on learning or do something else.
Blade Runner back here. Can you hear me?
I can hear you loud and clear.
Okay, I'm just
Are you
making
a
sure you
replicant or
can
a
hear
Blade
the
Runner?
Blade Runner. Okay. So, Jens, progress will move forward, and you have two guys that are standing up there to your left and right who are incredible surgeons. They are technophiles, Dr. Kim and Dr. Drazen, and the reality is somewhere in between. The reality is somewhere in between that this technology has advanced forward. These guys are the pioneers of making this stuff work. And it's really incumbent on us, people like you and me, to make sure that the surgeons that come behind us, understand that they know how to do these operations. Your pilot who flies out of here today, if he doesn't have instrumentation that can fly him out of the Seattle fog, he needs to be able to fly the airplane. And we as the surgeons are the same thing, is that we have to be able to fly our airplane or do these operations and understand the anatomy, and we have to use this technology to make us better surgeons. This doesn't make a surgeon at all. In fact, you can use some of these old jokes, that a fool with a tool is still a fool, And we have to be able to make sure that the young surgeons learn how to do the operations. They understand the anatomy. They understand the tissue planes. They understand how these things are supposed to work, and this technology makes them better, just like our pilots that fly us around. Okay, they're better at it than they were 20 years ago. That's for darn sure. So Blade Runner just had to chime in here. So thank you for the great talk. It's always entertaining.
We try. Thank you.